There are close to 1 million total knee replacements performed in the United States each year. And data shows that 40% of Americans are overweight. So, for many patients, the discussion of weight and surgery comes up when they talk to their surgeon about surgery. And I'm going to cover all of that information and more in today's video. Welcome back. I'm Rosen, and thanks for watching my channel. If you haven't already, please subscribe and click the thumbs up button if you enjoyed this content. So in today's video, I'm going to cover a lot of information, and I'm going to try to cover this in 3 parts. So number one, I'm going to talk about the idea of weight, or what we call the body mass index, and how that impacts your health. The second part of this discussion is going to be about surgery and what risks are involved in patients that are either underweight or overweight. Because a lot of times what I hear from patients is they were told they need to lose weight, and that was it. That was the end of the discussion from the doctor. And I'm going to explain to you why a surgeon might tell you that. And lastly, I'm going to share with you all of the tips and tricks and skills that I've just shared with my patients over the years to help them lose weight. So for starters, when we talk about weight, the most common thing that you're going to hear is what's called the BMI, or body mass index. Now, it's not a perfect thing. It is a screening tool, and it is a great metric to give you an idea of where you stand. So all you have to do is go online, input your height and weight, and you're going to get your BMI. Now, what you can see from this chart basically is that if you're 18.5 or under, you're underweight. If you're sort of in that healthy range, it's 18.5 to 24.9. If you're overweight, it's 25 up to 29.9. And the obese category is over 30. And they break that down into 3 classes, class 1, 2, and 3, class 3 being a BMI over 40. Now, why is that important? So from an orthopedic standpoint, there was a study that found that 16% of United States adults will develop knee arthritis. And if you were overweight, your risk of developing knee arthritis was 35%. So when patients ask me, is there any way to stop, prevent, or reverse arthritis? The answer for the majority of people is no. But if you don't have significant arthritis and you're overweight and you lose weight, you can essentially cut your risk of developing arthritis in half. And for a lot of patients that have pretty mild arthritis and have knee pain and are overweight, a lot of those patients can lose weight and get rid of their knee pain. If you have severe bone-on-bone arthritis, you can lose a lot of weight. You're still going to hurt. So that can play a factor in arthritis. But what a lot of patients don't understand is that weight can play a factor on every other system in the body. And when I bring up the idea of weight with patients, it can be a difficult conversation. I would consider it malpractice, however, to not bring it up. Because if I was your primary and I talked to you about diabetes, or your cardiologist talking to you about your blood pressure, there's really not a whole lot of issue or concern there. Patients expect it and the doctors do it. But when we bring up the idea of weight, patients can get emotional, they can get angry, they can cross their arms and sit back and get very confrontational. So I have to bring it up gently in certain instances, but most patients, from my experience, have been very open to talking about it because many times doctors aren't discussing this with them. They try to avoid it. And it might be because it's a difficult topic to talk about. It might be because nowadays doctors are concerned about Yelp reviews or health grade reviews, and they don't want to piss a patient off. Or time. Doctors are seeing more patients quicker to get through the day, and they just might not have time to cover everything. Maybe they can only cover your blood pressure at today's visit. But what I explain to people is that if we can help you lose weight, then not only will your knee pain improve, but your hip pain and back pain and foot pain will probably improve. And if you're going to have surgery, what we'll discuss shortly, it's going to decrease your risk of a complication. But I always tell patients, don't be surprised then to go see your cardiologist and for them to be happy that your blood pressure is lower, and maybe they can get you off of blood pressure medicine or reduce the medication that you're taking. And then if you see your endocrinologist, they're happy because if you had diabetes, your sugars are better, and they might be able to decrease the medicine that you take for diabetes. And if you see your primary who's been following your cholesterol, they're going to be happy that your cholesterol is lower, and they might be able to take you off medication that you're on for your cholesterol being high in the first place. So losing weight alone by itself can actually impact multiple things about your health, and it can improve all of them by simply doing this one thing. But more often, again, in healthcare, we're more reactive, where we would much rather give you an operation or a pill as opposed to doing something proactively and to prevent you from developing those diseases in the first place. So that's kind of weight in a nutshell. And again, it's not an easy thing to talk about, but it's important for patients to understand. And the patients that I do work with that do lose weight all come back and are extremely happy, because many of them have struggled with this for years, and they're happy when they see all of these improvements in all of their healthcare metrics. Now, when we talk about surgery, let's talk about surgery now and why a doctor might blanket statement saying, "You're too heavy for knee replacement surgery, come back and see me when you lose weight." And I'm sure many of you have heard that exact statement, and you're basically left like, okay, well, what do I do? The one thing I always tell patients about, though, too, is that if you're underweight, so if your BMI is under 18.5, those patients actually have a higher risk of complication than patients who have a BMI of over 35. Now, it's different when you start to get with BMIs over 50, but the underweight patient sometimes has to be told, listen, we need to give you an appetite stimulant, or we need to put you on protein supplements to increase your weight prior to surgery, because that risk of complication is there. But if you're overweight and you're going to have surgery, there is an increased risk of complication. Now, what would we see? We see an increased risk of blood clots, what's called DVT. We can see an increased risk of infection. We can see an increased risk of wound healing or wound complication. We see increased risk of ligament damage or rupture. We see increased incidence of loosening of the implant, early failure of the implant, or fracture of the bone around the implant. Now, that should resonate with most people to say, if there's something that I can modify prior to surgery to reduce all of those complications from occurring to me, I want to do so. And it's important. And that's why most surgeons will tell you, I want your BMI under 40. Most of our studies over the years have shown that BMIs over 40 do carry a higher risk of complications. Some studies have even shown that BMI over 35 also carries an increased risk of complication from people that are in the healthy BMI weight category. And many insurance companies have jumped on this and have said, listen, we're going to deny this patient surgery unless their BMI is under 40 or under 35. Or sometimes what they'll add in there is a 6 months of consecutive weight loss in a weight management program. So if someone's BMI is 50 and they get down to 44, that's an improvement. 6 months of consecutive weight loss, but they're still over 40, they might allow that surgery to proceed. And the idea behind that is different. I think as a patient, I would want to do everything in my power to lessen my risk of a complication, because knee replacement surgery is a great surgery, but the complications are all really bad. Luckily, those percentages are low, but you don't want to do something that gives you a double or triple chance of having one of those complications if you can modify it before surgery. Now, from a surgeon standpoint, the surgery is harder and longer in patients that are obese, because we have to get through a thicker soft tissue envelope. The incision tends to be bigger. A lot of that tissue tends to be not as healthy or robust as healthier tissue, so it can bleed more, it can drain more, it's harder to see, it's harder to manipulate the leg, so it makes the surgery harder, longer, and more difficult for the surgeon. And from the insurance aspect, I've never talked to them, but I'm sure they're just looking at it as, we don't want to pay for a revision if there's a complication, so we're just going to deny the surgery until the patient loses weight. So you have to kind of look at it from different areas. Now, you're also going to see regional differences. So where I work in Southern California, there are many people that are in that healthy BMI category. In my friends who operate in Chicago and Atlanta and Philadelphia, where the average weight of those people is greater, they tell me like, hey, look, if my cutoff was 40, I wouldn't be doing a whole lot of surgery. So my cutoff is 45. And I even operate on people with a BMI of 50. So depending on the demographic and depending on the surgeon, you might have different things told to you from different surgeons in different areas. So there's not one black or white answer, but the studies have all shown that the complications are higher, so most surgeons are going to have some cutoff for some particular reason. Now, it's multifactorial. So if I meet you and you're healthy, and the only risk factor that you have is your weight, that's one risk factor. And as long as you understand the risks and you have informed consent and you're aware of the potential complication, it might be safe and healthy to, or it might be safe to operate on you. Now, if your health conditions are multiple, so you're overweight and you're a smoker and you had a stent put in, so you have heart disease and you have diabetes and you have sleep apnea, now we start to add on multiple things, all of which carry their own risk, and your risks are exponentially higher. So in those cases, a surgeon might be a little bit more aggressive in saying, hey, look, you got to get rid of one or two of these things. You got to quit smoking and you got to drop the weight before we're going to take on the risk of your heart disease, which is chronic, and your diabetes, which is chronic, before we're going to put you through an operation, because the risks, in their opinion, may be too high for you to have a bad outcome and have a complication. The other thing that you have to understand, though, too, is that studies have been done, and they actually do show that patients whose BMI is over 40 still have improvements in their quality of life. So we're not going to try to deny care to everybody, because if you have severe arthritis and your BMI is higher, and you understand that there is an increased risk of complication, then there might be a role to go forward with surgery, because it's still going to improve your quality of life and your pain. There's just that added risk of complication. Now, many patients say, well, if I could walk and exercise, I would lose weight, but I can't because of my knee. And I hear you, and I understand that. There was a study done many years ago at Mayo, and what they did is they actually looked at hip and knee replacement patients, and they followed weights. And average weight at 1 year actually increased. So if you don't make the time or effort, and sometimes that requires assistance, to lose weight before surgery, it is extremely rare, and in my experience, I have not seen many patients lose weight after surgery. But if you embark on losing weight prior to surgery, and you have surgery, which improves your pain, function, all those metrics, and you can then exercise even more, a lot of those patients are able to continue to lose weight and get down to a healthy weight BMI. Before we go on to what I discussed with my patients, the other thing which I talk to my patients about, and what you should understand about weight loss is not simply a number, because what a lot of patients are surprised to hear is you can be malnourished and overweight. Malnourished, but overweight. And one of the metrics that we look at most commonly is what's called your albumin. So when you get your blood tests, you can get a BMP, basic metabolic profile, which looks at your kidney function and your electrolytes. What I recommend is most patients get what's called a comprehensive metabolic panel, which also includes a metric called your albumin. This is your protein stores. And studies show, irrespective of what your weight is, if your albumin is low, those patients have a higher risk of wound complication, drainage, and infection. So if you're overweight and your albumin's low, that's a major risk factor for you having a bad outcome. So you want to bring the weight down, but nutrition is important, which is what we're going to talk about shortly. And if you're trying to lose weight and improve your nutrition, you want to see that albumin get back to normal prior to surgery. Now, there's another test called a pre-albumin, and the albumin corrects very slowly. So if your albumin was low, you've improved your nutrition, your pre-albumin goes back to normal. It's a pretty good sign that you've gotten back to where you need to be, and over the next few months, the albumin will return to normal. Now, there are other labs that some surgeons will order. I do on occasion order additional labs when we're looking at your metabolic profile. And this is really important if you've had bariatric surgery. So a lot of patients at bariatric surgery lose an incredible amount of weight, but a major component of that recovery is nutritional supplementation. So a lot of these patients are losing weight and they've dropped a ton of weight, but they're malnourished based on their labs. So those patients, although their weight is lower, still have a higher risk of complication because laboratory-wise, their body is malnourished. They don't have the nutrients to heal a surgical wound after surgery. So all of that being said, I have tried to make it a habit to never just tell patients, look, lose weight and come back and see me when you do. Because that's not really being a doctor. That's basically blowing a patient off and hoping that they don't come back to see you. And to be honest with you, when I bring up the idea of weight, sometimes I never get this far into the discussion. Patients will get upset, angry, and leave. and I'll never see that patient back. And if they find another doctor that's going to operate on them, hopefully they do well. But we're trying to improve their health overall, not just their knee. So what I explain to patients is that I'm not a nutritionist. I know a lot about nutrition, and I know a lot about weight loss because I've taken care of patients for the past 2 decades. But I always involve and offer the option of a referral to a nutritionist or a referral to one of our weight management specialists. These are not bariatric surgeons. These are doctors that will also work with nutritionists and sometimes use medications to help bring their patient's weight down in a safe manner. Now, nutritionists are hard because I've had some patients that see a nutritionist, and nutrition is not a simple black and white answer. There's different philosophies and techniques. So a nutritionist has to be willing to work with a patient to help them change their lifestyle that will allow them to be happy and healthy and lose weight all at the same time in a nutritional way. So that sometimes I tell patients takes 1 or 2 or 3 go-arounds until you meet a nutritionist where you do jive. The other thing I recommend to a lot of patients is I've had a lot of patients in the past few years have had good success with the app Noom. Now, I have no relationship with Noom, but it is an option that you can look into because, again, it works with the psychology that many patients struggle with. And this is where I start with patients. I say, look, most of you know what the issue was that led to you gaining weight. For many people, and in some patients it can be just simply biological, but for many patients, they have a vice. So is your vice portion size? Is your vice salty, crunchy stuff? Is your vice sweet stuff? Is your vice alcohol? Is your vice midnight snacking? You know, every patient usually has 1 or more of those vices, and they know that's their downfall. They shouldn't, but they do. So we have to first identify what that vice is. And if you're a portion size person, instead of 11-inch plates, go to 8-inch plates. For people that cook at home, you know, I tell them, hey, look, make your plate, put all the leftovers away, sit down and eat your meal. Because if you have the serving bowls, you're more likely to take an extra scoop or 2 and keep kind of filling up. That is one thing. If you're a salt or sweet person, what I tell patients is, look, you don't have to avoid the salty, sweet things that you enjoy, but be aware of what a portion size is. If you get a small kitchen scale and you actually measure out what a portion size of potato chips or pretzels are, most people are surprised that that's it, that's a portion size, because you could sit with the bag in front of the TV and you could eat the whole bag and you've just eaten like 8 portions. The same thing with ice cream. You know, if you like sweet stuff and you like that sweet treat, instead of bringing the pint and a spoon over to the sofa in front of the TV, get a small little bowl or a ramekin and take a scoop, put the rest of the ice cream away. Now, the other part of that, what I just mentioned though, is mindful eating. Many times we're sitting at a kitchen table with our face buried into an iPad or a cell phone, or we're watching TV on the sofa, and we're not even aware of what we're eating or how much we're eating or how it tastes. So the idea of mindful eating, of actually stopping, looking at things like this, if you're looking at this while you're eating, and actually paying attention to chewing your food, how it tastes, what the texture is, chewing it multiple times before you swallow it, which also aids in digestion. All of those things can make you more mindful of what you're eating and how much you're eating. And that's the other important thing. If you slow down what you're doing and how you're eating, your body is going to recognize that you are fuller when you are full. If you keep eating quickly, your body fills up with all this food before that signal goes to your brain to go, hey, I'm full, I'm going to stop eating. And that's another trick that I talk to my patients about, is the idea of eating a glass of water, or drinking it, not eating a glass. Drink a glass of water prior to each meal. So if you fill up a glass of water and drink it, it starts to distend your belly. And if you do so, again, your body is going to recognize that feeling of fullness earlier, which then allows you, or hopefully gives you the impulse to stop eating and realize that you don't have to clean your plate at every meal. If you're full, you're full. That's the important thing. The next thing is exercise. So a lot of times what patients do find is that if you exercise prior to eating, you tend to want to eat healthier and not eat as much. So before breakfast, I encourage patients to go out for a walk. even if they have the ability before lunch or before dinner, is take a walk. Sometimes after dinner, it's nice to take a walk after dinner, because when we're moving, our intestines are hanging down and they're kind of moving back and forth, which also aids in digestion. The other main portion of food that I tell a lot of patients is what you're eating as far as the nutritional value and the products that you buy. So for most people, and I always use this story because there was one patient that I ever met, and this one patient is wealthy enough that they don't do their own shopping. Every other patient that I've met, including myself, does my own shopping. So when you go to the supermarket, do not buy the things that you know you should not buy. If they're not in your house, you're not going to eat them. If you buy the healthy foods that you know you should eat, you're more likely to eat healthy at home. And when you buy foods, what you should buy are whole foods. So fruits and vegetables. And eat what is in season. If you eat the rainbow, the different colors of different fruits and vegetables signify to us what minerals and nutrients are in them. So if you're eating things that are of different colors, you're getting all of the nutritional requirements. And again, most Americans don't eat enough fruits and vegetables at each meal. So I always try to tell people, try to at least have a serving of fruit with each meal. You can have it with breakfast, lunch, and dinner. I'm a big fan of blueberries, but any fruit that you like. Bananas in the morning, blueberries usually with lunch, and I'll try to have some fruit or vegetables with dinner. But I'm trying to get that. Now, if you're diabetic, you might not be able to consume that much sugar, so have more vegetables. The other thing is less meat, and it doesn't mean that you have to go vegetarian, just maybe one less meat dish a week, and try to consume leaner meats if you're a meat eater, or try to transition over to fish, which tends to be healthier for you, also better for the environment. The other thing is a lot more fiber. Most Americans do not get enough fiber, and fiber is good for a couple of reasons. One, it's good for your bowel habits. It's going to improve your bowel habits. But also, when you eat foods that are rich in fiber, and also foods that are rich in healthy fats, you will feel fuller for longer. So, for example, if you had a meal with sweet potatoes, or you had a snack of almonds, after both of those eating episodes, you're going to be full for a while. If you ate a bag of potato chips or a bowl full of pasta, those carbs and sugars are going to burn off pretty quickly, and you're going to be hungry right away. So adding more fiber to your diet and more healthy fats, so nuts and avocados are great healthy fats, you're going to feel fuller for longer, which means that you're going to consume less food, less calories, but you're also probably going to feel healthier, and you're going to have more energy because of those better nutrients. Now, when we talk about weight loss, the other thing that I talk to my patients about, kind of two things. The idea of 50. So what I tell my patients is, look, if you're trying to lose weight, don't set a goal weight. Try to lose 1 pound per week. And if you measure yourself and you lose 1 pound this week, perfect, you're right on target. If you lose 2 pounds, great. Still try to lose 1 pound next week. If you gain a pound this week, okay, that's fine. Try to lose 2 pounds next week and catch up. But it gives you a more realistic goal. And if we eliminate Thanksgiving and Christmas, which people tend to eat a little bit more, or maybe your vacation week, you're still going to lose 50 pounds in a year if you need to lose that much weight. But if you set a goal weight and you're constantly saying, I want to get down to this weight, every time you get on the scale, you see how far away you are from that number, it can be very discouraging. So that idea of 1 pound per week is a very healthy way of patients kind of looking at this as a long-term issue, because the mistake that a lot of people make is they go on a diet. And a diet, by definition, is short-term. You change everything you do as far as what you eat, you lose weight, and then you go exactly back to how you used to eat, and you gain the weight back. You yo-yo, which is not a very healthy way of going about losing weight. So you need to change the way that you're eating. So it's changing the portion size, changing what you eat, when you eat, how you eat, and maintaining those changes long-term. Lifestyle changes. That's going to help bring the weight down. Now, the other thing that I talk to patients about, because this can be extremely frustrating to a lot of patients, is what's called the plateau. And this is what we'll end on. But the idea of the plateau is you have to imagine you have a certain amount of weight or mass. And when you walk and when you do things, you're going to burn a certain amount of calories. And for patients that have pain, You know, they're like, I can't exercise. I'm like, look, if you walked into the office, you can walk. So if you can walk 5 minutes every day in the morning before breakfast for exercise, it's great. If you can't do 5, do 2. It might be up and down the block. But if you can do 5 this week, then next week try to do 10. And again, if you can't do 10, do 8. And if you can't do, that 8 every day, do it every other day. But eventually you're adding 2.5 to 5 minutes every day or every other day for each week. And what you'll find in 6, 8, 10 weeks is you're now walking a half hour. So let's say we're up to walking a half hour. You're eating healthy, you're losing weight. And now all of a sudden, you've plateaued. You're still walking 30 minutes every day. Maybe you're riding the bike because walking hurt your knees too bad, but you're doing some form of physical exercise every morning, 30 minutes. You're religious about it, and you've changed all of your eating habits. You're eating healthier, whole foods, high in fiber, drinking a glass of water before your meals, and you're not losing any weight. This week it's 0 change, next week it's 0 change, and you get angry, you get frustrated. You're like, what am I doing wrong? You've become a more efficient machine. Because you weigh less, when you walk from point A to point B, your muscles are burning less calories to get you from here to there because you don't weigh as much as you did 3 months ago, which is a good thing. You've actually lost weight and you've become a more efficient machine. So there's a couple things that you can do. Number one is you can see if you can cut back your portion size, your calorie intake a little bit. You can also see if you can increase your exercise a little bit. Strength training is a great thing to add in if you're doing cardio for your weight and vice versa. If you're doing strength, add in cardio. The other thing that you can do is you can add weight when you walk and exercise. Been commonly referred to as what's called rucking, where you basically wear a backpack and you can put a couple water bottles in it and you can add some weight back. If you have weight on your back, it's actually improving your posture, strengthening your core. You can actually buy fancy vests where you can put little pockets, 1 pound pocket weights in the front and the back. But you're adding weight when you go to your walks, which is burning more calories because your muscles are requiring more energy to get you from point A to point B. And that's going to get you, as you were losing weight, on the plateau and then back on that downward trend again to whatever your goal weight might be. So this has probably been one of my longer videos. I hope for those of you that were interested in this information, it was very helpful. And I will put some chapter little notes. So if you want to go back and review specifically the surgical issues or the BMI issues and weight health issues, as well as the weight loss issues. And what I'll also do is I have a little handout in my office. It's my top 10 weight loss tips that I share with all of my patients. And I'll put those top 10 in the show notes so you can go back and read those at your leisure. I always tell my patients, you know every single one of these, but sometimes reading them and seeing them helps reinforce the importance of them. So again, and like always, it's been a pleasure to try to share some of my knowledge with you to hopefully educate you and offer you insight into things that can improve your health. Thanks again for watching, and until next time, I'm Adam Rosen. Stay safe.